Hi, everyone. So I'm Dr. Craig Alter, and this is going to be a very practical discussion today. And I mean discussion because I do have slides and they're going to orient us to the topic, but please feel free. This is meant to be interactive. If this was in person, we would be going back and forth, back and forth, back and forth. And Amy's going to help also with the questions. I don't want to wait to the end for questions. I'd rather be interrupted and any comments you have. Okay. So with that in mind, I'm going to share my slides. And I'm assuming everyone here could see the slides.
You're good.
Okay, good. So I call this the top 10 things to prepare for your visit with not just the endocrinologist, but also with the neuroendocrine providers. And I realize it's actually not a simple thing. You might be seeing, depending on your child's diagnosis, an endocrinologist, a nurse practitioner, an ophthalmologist, a specialized ophthalmologist that deals with the brain, neurosurgeon, perhaps, sometimes social workers. You're not visiting with a neuroradiologist, but you might be getting MRIs. So there's your neuroradiology. And then you might be seeing oncology. So if someone here has like a germ cell tumor, you're working with oncology as well. And when you have a craniopharyngioma, which I imagine is the most common diagnosis for this conference, sometimes you're seeing a neuro-oncologist, sometimes you're not. Okay, so those are the players. So now, can anyone tell me what game this is from? Start making this a little interactive. I wish I had the music to it. If this is a big pharmaceutical thing, they'd be blasting the music. We probably have Alex Baldwin here in person, although I think he's a little tied up these days. So this is from the match game. And what Alex Baldwin would like to ask you is that, what are the endocrinologists thinking they want to accomplish during a visit? So anyone want to throw in any comments of what they think in endocrinology? Like when I'm about to see someone, let's say, who has a pituitary tumor of any kind, what am I thinking about at the visit? I would say, oh, I'm seeing Jose. I do want to make sure we cover A, B, C, and D. Let's see if anybody has comments. If you don't make comments, of course, I'll move on, but I'll give you a few seconds. I don't know, Amy, is anyone entering anything? Because I can't see.
So we have, Erica says, get the hormones regulated.
Okay, so that we'd be thinking of all the hormone systems, probably the most common thing we're thinking of, whatever they are. It's also trying to remember, it's not like I absolutely remember what everyone's on. It's not like I say, oh, this person's on a high dose of thyroid, low dose of thyroid, or offhand. I may not have seen them for 6 months. There are a lot of things, or they may be new to me and stuff like that. Or if they're 5 years old, we're not going to think about testosterone, but I may want to mention it if it's a boy, and estrogen for a girl. Any other comments?
Everyone can put comments in the chat if they want to, but I don't. Oh, here's one. How are they doing tracking growth and weight?
Okay, yeah. So how they doing on the growth chart? Absolutely. That's like, when I see a growth chart, I say, I just saw a picture of your child. So that's our photograph. Okay, I'm going to move on here. And so we'd like to know about any big events. Did your child go to the emergency room? Was there something big at the school? There was a seizure, there was something, you had a visit with an ophthalmologist and they were concerned about something. You had an extra visit with your pediatrician because of COVID, whatever. So we definitely want to know events, because there's, at every event, let's say you did go to the pediatrician with a concern of COVID, that immediately makes me think, tell me how you thought of the steroids. Did you give stress steroids during that? Did you not? How much did you give? And things like that. I also will ask when you've used steroids, for stress steroids. That I consider event as well. And it'll lead to a discussion of when to give stress steroids. And I always like we always like to document in the notes that we discuss stress steroids, because that's just very important. The tumor status, you're coming to us for hormone regulation, but how is the tumor doing to begin with? It's not like, that's a simple question. Did you see neuro-oncology? Did you see neurosurgery? When was the last MRI? Ooh, the last MRI. And it's not always done at our own institution. So it's not like we always have the answer. We did an MRI in New York, even though I'm in Philadelphia, and it showed something. I said, well, we don't actually have the report. So there's a little give and take there. You already talked about hormone replacements, growth and puberty, and then compliance. That if I have you taking a DDAVP, desmopressin at noon and hydrocortisone at 2 p.m., that's not a really convenient plan. So I have to see, first of all, are you able to, whatever the plan is, do it? And number two, is there anything to help with compliance? Like you're forgetting the thyroid hormone in the morning sometimes because the bus comes, they come early, the bus driver is a little crazy. And then what about giving thyroid hormone at bedtime? And you might say, well, that's not really enough time after eating. And I said that I would respond, well, if you're missing it, that's the worst. So I'd rather you not be perfect on the eating part and know that you're getting it. Or maybe you need a pill box for everything. So there's a lot of discussion or thoughts about compliance from our end, because we know it's hard. And then coping, forgetting about all the hormone status. How are you doing? Is this person have friends? Are they going out at all? Obviously, COVID throws a little wrench into things, but that kind of stuff. And I don't often go into this because it's a little uncomfortable for the provider, but it's also, I do go into it sometimes, which is that financially, it might be that this may be an important one actually for your provider. If you're paying a lot for the growth hormone, because that's the most expensive medicine that your child will be on, and you may say, well, unfortunately, that's just the cost of having a craniopharyngioma. Maybe not. It might be that we have a way of getting it cheaper. There's a lot of companies have copay assistance cards. How many people use a copay assistance card for growth if you're on growth hormone? When I say on growth hormone, I mean your child, but that's okay. Do you even know about it?
So we have one answer, we do. My family personally has used it before, depending on insurance, what the insurance is covering.
So a lot of people think that, well, I'm not going to get a discount for the medications because I make too much money. Not that I make enough money, but I make enough money that I'm not going to send them my financials. Well, Bill Gates and Jeff Bezos would qualify for certain of the discounts. It's not income-based. Some of them are. If your other ones are income-based. So for example, Novo Nordisk has a special copay assistance where at the beginning of the year, they will give you, they change it all the time, maybe $2,500, maybe even $5,000, no more than that, towards your copay. And that's pretty amazing because if you have a high deductible, that will cover your high deductible. The insurance company is not going to say, well, you're not really paying it, they're giving it back to you. No. So if something is really expensive, you should bring that up. And I think that we're interested in it, but often it doesn't come up. Okay, if any comments, these are issues for us that we're thinking about. Now I'm going to move on to what about you? But there are other things that go beyond our expectations. For example, you might say, well, we need a letter for the school. So August is famous for that, especially with type 1 diabetes, but even for our kids, letters for the school, forms to fill out, physical exam forms. And there's always lab slip forms at the visits. There's insurance appeals. So that covers a lot of time. That's mostly off after the visit. You may not realize that when I appeal a growth hormone, it probably takes me 30 minutes. It's not a 2-second thing. Sometimes it's shorter, but it could take a lot of work. Then there's EMR, electronic medical record completion, like our EPIC, as we call it, the most common electronic medical record. There's a lot of work after the visit to be done too, stuff like that. So these are all parts of our goals during the visit. Prescriptions, we really want to make sure we're giving you all the prescriptions. That's the best part of the electronic medical record, as far as I'm concerned, because doing a refill for a drug that really hasn't changed, like desmopressin, it takes maybe 20 seconds versus it would normally take 3 minutes. That used to take a long time, about a third of the visit, just the prescriptions. And then for the visit, unfortunately, there are sometimes delays on our end and there are delays on your end. So before we get to how to be most efficient at your visits, I want to define what these delays are. So what do you think are some of the delays on our end? Like things that these are all the things I said I want to accomplish: the hormones, the growth, the compliance and all that stuff, perhaps financial, but I also have to do letters and forms and lab slips and prescriptions. That's fine, but what are things that interrupt this, that make this process less efficient?
I just posted your question in the chat.
Okay.
So anyone can chime in there and I'll read it off. Lunch, just kidding. Prescriptions.
Well, wait, I won't, I'm going to count that. I didn't put that on my thing, but that's true that if you're my last patient in the morning and we're really behind, and I can see registering as my afternoon patient, I do want to grab something to eat. And I want to go to the bathroom too, by the way. So
the rule would be don't make the appointment at 1 p.m.
Okay.
Other emergencies.
Tell that to my division head. Okay.
Other emergencies that arise during the day, Rachel commented.
So medical things that a patient, what if it was your child and it was new onset appearance that you found out someone is in the emergency room, a 7-year-old who's had headaches, some blurry vision and has been fatigued, and the doctor diagnosed a pituitary problem, and you hear the story and you say, I know they need an MRI, and they have some sort of pituitary tumor, clinically is the most likely thing. You're going to be on the phone for 10 minutes with emergency room, making sure they don't get a brain MRI, but get a pituitary brain MRI, which is a little different. Things like that. What lab should they get? All that takes time. Okay, so we're going to move on, and I'm going to define the delays on our end. Dun, 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 dun. Okay, first you're in the visit and the nurse knocks on the door. Hold on, please. And then it's the nurse wants to ask you a question, probably about a different patient, or a fax came in for this patient. There's so many things. And you guys talked about call from an outside doctor, so someone unrelated to you. And then what about my own child is having problems? And I said, yeah, I'm also a dad and a human and stuff like that. And what if I get a personal call during that? Yeah, I could punt off some of them, but not all of them. And then the computer freezes. And I say, oh, why will this epic problem, this program is not letting me change screens? That happens. And I'm sure you've been in a visit where the printer wasn't working right, either lack of paper, paper jam. The doctor who's not an expert says, let me get Derek, who knows how to fix the printers and things like that. That could be a 4-minute delay right there. And then all of a sudden, the last patient I saw, when they went to check out, they said, oh my God, I forgot to ask the doctor this question. So there's that knock on the door about that. So there's a lot of things that will delay on our end. So what do you think delays things on your end? These are things that kind of on the hospital side.
when
So what
patients
I
and
could see.
families are late to appointments, so maybe traffic, which can happen around CHOP for sure.
Oh my God. So in our hospital, I would say at least twice a day, I'm getting a text message from one of our staff saying, listen, patient Sarah Jones is running into bad traffic. There's an accident on 76. They're going to be 10 minutes late. And I will tell you, when we see that message, no one is ever 10 minutes late when that happens. I mean, 10 minutes late until they get into the Philadelphia region. It's probably 25 to 30 minutes late if I get that message.
There's
Right.
some other good ones, filling out forms for insurance info in the waiting rooms. The child or patient doesn't want to leave the playroom.
Oh, yeah.
Yeah. So
Yeah. So that's true. So it's not that you say, come on, let's go in the room. I don't want to go in. I don't want a blood test. Okay. Well, that could delay things too. And guess what? You may have other kids and although they may not have a pituitary tumor, they may have had the Halloween parade today. And, that's the way it is. Okay. So let me go. So here's what I wrote first is that arrival at 10:03 for 10 a.m. appointment. Different practices are set up differently, but I could tell you that for us, it's a little unclear when someone's supposed to arrive. That if I have a 10 a.m. patient, then I'm hoping, but not always expecting, that they're weighed and measured and in the room for me to see them at 10 a.m. So imagine the 9 a.m. patient is in that traffic jam and finally arrives at 9:25. Well, there's another 12 to 14 minutes before they get put in a room between the blood pressure, height, and weight. So now they're 45 minutes late. And I have the next patient in 15 minutes. Really uncomfortable for us. Very, very uncomfortable. And I think different doctors handle it differently. I like to go into the room and say to the next patient, listen, I just want you to know that, I can't wait to go over the MRI. I heard it was really good. And I'm excited to go over that with you. But we're running a little behind. The last patient came a little late. And so whatever, I may give a reason, may not give a reason. But I sort of touch base with them so they know that they're being thought of, almost like you're a waiter at the table. It's nice when the waiter or waitress says, listen, I'm checking on your food, and it's been a little delayed, but I'm going to the kitchen and going to find out. It's kind of nice to know you're not forgotten. And then here are all the things that I want you to overcome. Okay, the lateness part is you do your best. I could tell you if you come into CHOP, Children's Hospital Philadelphia, the first time, and you say the 10 a.m. appointment, and you got there at 9:45, and you say you're right at the front of the parking lot, you might be up on our floor at 10:20. It's like the parking is terrible right now. They're doing construction and stuff like that, and so I don't, it's unfortunate, but that's the way it is. But know your doses of medicine. Seems very straightforward, but a lot of people don't. I'll say, what dose of thyroid? You may say, well, can't you just look on the chart? Well, I can, but you are my backup to make sure it's the right thing. Because how do I know that you weren't on the levothyroxine 100 microgram, which is yellow, and that on the phone, either me or one of my colleagues when I was in France on vacation, I called you up and said, you know what, let's go up to 112, which is pink. And then, or your primary care doctor did, or I don't know, your Aunt Carol told you to go up to 112. So you really need to know your medicines. And if you don't know them, take a picture of them. Either if you don't have to bring them in necessarily, take a picture so that we say, what's your dose of thyroid medicine? Oh, I have it right here. What about testosterone? Oh, we got it right here. Growth hormone, got it right here. Know which pharmacy, because I hear this plenty of times in a week. Which pharmacy do you use for the growth hormone? Oh, the growth hormone. No, it's not the CVS. It's the, what do you call that? I know I speak to Jessica. I speak to Jessica all the time. I don't know Jessica. So that one will take away 2 minutes, maybe 3 minutes of the visit. You may have to call home and my husband and my wife handles the refills. I give the injections and my spouse calls up for the refills. Well, I don't think you want 3 minutes going towards finding out what pharmacy is, unfortunately. And then here's one that almost no one knows. So if you want to go top head of the class, is if you're on growth hormone, you typically you may have a pen device and a little tiny needle that you put on it. Okay, so I'm going to ask everyone in the group here, how many of you's child is on growth hormone?
Everyone can post in chat or raise, I think the raise hand.
Yeah, and if it's not now, anytime in the past. Who's been on growth hormone?
So we have a couple, we've got some on, some not.
Okay, so growth hormone, for those that are not, is not given out by your regular pharmacy. It's one of the special pharmacies because it's under lock and keys, special refrigeration and things like that. It's not, can't just go to your local CVS and get it. But if you have a needle tip, for those that are on it, do you know the size of your needle tip? You don't even have to answer me, but you may say, people always say to me, oh, it's the small one. Well, let me tell you, they're all small ones.
Leah says it's purple. I can tell you, I don't know.
Okay, see, that's what I mean. So this is why I want you to learn from this. So purple is probably the pen, unless it's the pen needle. So purple pen is 30 milligram nortropin, if that's what you're on. But the pen needle tip, it comes in different wrappers. There are two parameters for the needle tips. There's the gauge and the length. The gauge tells you how wide the needle is, like the diameter. And almost everyone has either a 31 gauge or a 32 gauge. 32 gauge is a little bit less wide. So the higher the gauge, actually, the smaller the diameter. And you may say, well, why don't you just put me on the smallest one? Because if you're on the smallest one, sometimes it doesn't squirt fast enough and you lose some of the growth hormone. And then there's the length. It's either 4, 5, 6, 7, or 8 millimeters in length. And we can prescribe all of them. And it's not like they all probably work, but I like to keep you on the same one and not figure it out. And if it involves a phone call home, say, honey, can you check which needle size it is? That's another 3 minutes. And you can see how many 3 minutes add up to your 30 to 45 minute appointment. Okay, then you're almost definitely going to be asked, when do we use stress dosing of the steroids? And that it would be good to have that organized and say, well, we used it before this procedure where my husband and I, my wife and I had a debate whether when Ginger was taking her final exam, this came up in the last talk, the 2 talks ago with the questions, if stress doses should be given. And we debated it. We ended up doing it, but just like a little stress dose. So I think I'd like to hear what my families are doing. I like to know. In particular, I want to make sure they're not doing it too much. And I want to make sure they're doing it at the right times. So that's an important part of the discussion. But if the first part is you have to really think, oh God, when did we use it? That's wasted time. So you can see another area where you could save time. Okay, the next one is, and this is a really common one, is that you see me today on November 12th. And I look in the chart and I say, oh, good, they did labs. Oh, they did it 2 days ago on November 9th, Thursday. Yeah, well, guess what? We have the chemistry panel and half the labs are not there. Oh, really? They're not there yet? Oh, we were hoping. Well, let me tell you, you should be doing them 2 weeks ahead of time in order for them to be ready for the visit. Now, sometimes you're doing them at the visit. That's fine. That means that we won't have them, of course, for discussion. But if you want them for discussion, you can't do them 2 or 3 days early. Some of the labs, which we'll get to in a moment, take a long time. Any questions about that one? About the labs? And listen, we know everyone's human. And if you come to me and say, you know, we really want to do the labs, we just finally got an appointment at LabCorp and it was yesterday, then you know, we deal with that. That's okay. In the past, No one got labs ahead of time. That was before maybe 12 years ago. Everyone came to the visit, they got the lab slip, and they went from there. So it's like a nice thing to have the labs done. But if you only did it 3 days ahead of time, we won't have it. The other thing is, if you did do labs, let's say you did it last month, that's great. If you're on testosterone, we do want to know how many days after the testosterone were the labs done. I'm going to repeat that again. If your child is on testosterone, and maybe you have a 4-year-old boy, well, he's not on testosterone yet, but someday he will be, perhaps. And if that's the case, then in order for me to interpret it, it makes a big deal if you gave testosterone 3 days ago and checked the level versus 10 days ago versus a month ago. I have to interpret it accordingly. And then finally, I would say this happens at least 4 times a week, that someone got a bone age x-ray. So how many of your children have had a bone age x-ray? This one should be a lot, even if you weren't on growth hormone.
Mine has. Yeah, it's coming in.
Coming in. Okay.
Yeah, a few people.
So how many of you bring the disc to the doctor?
So we have not had a bone age x-ray, but want to know when we should start or have one done. As far as your disc question, so that would be probably if you got an x-ray or bone age outside of the hospital where you're seeing the doctor.
That's right.
Yeah.
So that's true. If you're doing it so for example, if you come into my hospital, if you had your x-ray done at any facility that's with our system, whether it's at a satellite or the main hospital, then we'll be able to see it. But a lot of times the insurance makes someone do it on the outside and stuff like that. And then
yeah, I'm sorry. And someone said they had to follow up and request the disc. I will say, learn from experience to always ask for it, because even if the place you're getting the x-ray done says they're going to fax the results over to the doctor, I've never really had much success with that.
Okay, so I will elaborate on that, because that's exactly my point, is that I'm constantly hearing a parent say, oh, they said they would send you the result. You don't have it? Oh, they told me they would do it. And what happened is that they will eventually fax their radiology reading of it, which is nice, and it's nice to compare, but most of us like to see the bone age x-ray ourselves. And I tell the family, they will send the report, maybe I even have it, but they never send the image, at least in 2021. I imagine eventually we'll be able to just click it and see any x-ray. But for now, you have to get the disc. You have to ask for the disc, because they won't, some places just hand it to you and some places don't. And don't think to ever send us the image.
Sorry, Dr. Alder. I have a question. Should a patient have a bone age x-ray regularly, especially if they're on growth hormone?
Typically, we do a bone age about once a year. That's to be the most common answer that endocrinologists would give for getting a bone age. If someone's going through puberty rapidly, which is not great in terms of growth, it's good for a short-term growth spurt, but it's using up the time of growing quickly. Sometimes we'll get a bone age sooner, but pretty much that's it. It's about once a year. And it tells us how much growth is left. And it's nice when the doctor, I think, reads it in front of you, because then you get to see that this is not exact science. If you ask me what 8 + 3 is, instantaneously, I'm going to say 11 and smile. But if you say to me, is that bone age 11? I'll say, well, this part kind of looks like 11. This part might be 12, but the other part looks like 9. So what am I supposed to do with that? I'm going to say, well, the bone age, yeah, I'm reading as 11. But it means that someone else reading it, they may have said 11 and a half. Someone might have said, well, there's a definitely part that looks like 12. Let me call it a 12. You got to realize that you take it with a grain of salt. Okay. And I don't trust outside radiologists. They know the names of the bones much better than me. I always think they should be better at reading a bone age than me. But I have so many times I get an x-ray and say, how on earth could they call this a 7 when this is a 10? I don't even understand how they could even think of it. It's not even close to that. So that's why we like to see it ourselves. And one of the errors I've seen sometimes, if your child has an unusual name for, let's say, an American, then sometimes the radiologist who doesn't see the patient analyzes if it was a girl instead of a boy or vice versa. Okay, so what can you guys do to become more efficient at the visits? It sort of falls out from everything else we talked about. First, I think you should come in asking yourselves beforehand, what's your most concerning issue you have about your child? Is it just that your routine follow-up and want the hormone levels? That's fine, but there might be stuff about social and behavior to discuss. We may not have a perfect answer for that, but I think it's worth bringing it up. There might be some resources. Is it about medication? And you should know if there's a compliance challenge. Like I talked about, giving a medicine at noon and then at 2 p.m., doing it on fasting, it makes the kid late for the bus. There's a lot of things that we could talk about to improve compliance and make it socially more acceptable. If there is a cost issue, I don't think you should be shy about it. You could say, doctor, I just want you to know that the testosterone, it's about $473 a month. And I was wondering if that's right, if there's any way to get it cheaper. And then there might be a discussion to how it, and maybe the answer is shop around another pharmacy. Look at 3 pharmacies in the same price. No one really ever does that. I don't do it for my own kids, but if I had an expensive medicine, I might do that. Okay. All right. What are you concerned about the vision? If there's something about the vision, bring it up. I know we're not the ophthalmologist, but it might mean that we call up the ophthalmologist and say, listen, I know you're due for the follow-up is due on Jason Smith in July, but maybe we should move it up to February. Okay. Have your medications organized. This follows from what we just talked about. Know the doses of your medicine. Know the needle tips that we talked about. Know your pharmacy names for both the medications and the growth hormone. Absolutely know which lab and x-ray facility is allowed, because this is what happens a lot. I would say this is also a few times a week, not necessarily with a pituitary patient, but I'll see a patient for a growth evaluation, and I have a lot of labs to order in this child, and I'll say to them, which lab do you use? I say, well, I don't know. We never had labs before. I know that my husband used Quest, but no, we have different insurance. It's really good. We're a lab heavy field. So it's really good to know if you use LabCorp, and I usually give them a choice of 4: LabCorp, Quest, my own hospital, or quote, none of the above, like Doylestown Hospital. And it's really important to know that. And I have to, when I fill out lab sheets, you would think that, okay, I could just specify whatever lab. No, I write my lab, I click off maybe 9 labs, takes a little time. I have to think about it, make sure I don't miss anything. And then I have to tell it LabCorp. So if 10 minutes later, you realize that it was Quest, guess what happens? That's the knock on the door for the next patient. The nurse says, doctor, can we just talk to you for a second? Sure. The last patient said they have Quest, but they actually use LabCorp. Oh, so now I have to go back on the computer and rewrite the entire set of labs. That's about another 4 minutes away from that next patient, unfortunately. Okay, so really know which lab you have. And how do you find out? You may have to call the insurance, but most of you probably know by now because it's not your first visit to the doctor. And know where you can get x-rays done as well. Because I'll say, can you do the x-rays done at my own hospital? They'll say, ooh, good question. And it might be that after the visit, you work that out. Because at that point, I don't really need to know. But if you do it on the outside, get the disc. We talked about knowing the needle sizes for the growth hormone. It's okay to take pictures of your medicine as well. And it's also a good idea to know when your next appointments are. So if you tell me, yeah, we're due for neuro-ophthalmology, because I'm going to look in their neuro-ophthalmology note and it says follow up in 6 months. Well, 6 months, that was from July, by the way. So that means that it should be by January. And if I look up and you don't even have an appointment, I might say, oh, you should really call right away to get that set up and things like that. So it's good to know your other appointments. And then just a couple more slides, and then we're pretty much done. When you leave the doctor's office, I think you should know all this information. Know when and where the next lab should be obtained. Do we need them done before the next visit? Does that have to be 2 weeks after testosterone dose? What's the plan for that? If you had labs done, how will you review the results with the team? Just don't assume it's just going to happen. You should say, the doctor, are you going to send me a letter? Are you going to send me a note? Should I contact you? Every doctor and family is going to work differently on that. That's a really important one to organize correctly and just not leave it up to chance. Do you have the next appointment set up? And when should it be? What are your doctor's biggest concerns? You said your biggest concern. You should know, is the doctor concerned that about the craniopharyngioma is growing? What's the doctor concerned about? And then of course there's the usual thyroid growth, diabetes insipidus, adrenal, and prolactin. So all the things that might be discussed. You may not discuss prolactin, that's fine. So these are all things by the end of the visit you should know. And the last slide, I really wasn't going to put any more slide in here, but these are just the typical labs that we get. Free T4, IGF-1 for growth hormone. If we're still deciding if your child can make adequate steroids, hydrocortisone or cortisol, same thing, then we'll typically get a 7:30 to 8 a.m. cortisol. Prolactin, sometimes we get sodium, especially if you have diabetes insipidus, glucose, because growth hormone can raise this, as can steroids, and just obesity can raise it. These are puberty hormones, LS, FSH, estradiol, and testosterone. There's a girl estradiol, a boy testosterone. And don't usually get urine concentration. That's an uncommon test. And that's all I wanted to say about how you can make your visit the most efficient when you see the doctors. Any other questions?
Thank you. Yeah, if we have questions, you can put them in chat, or you're welcome to turn on your camera and mic and ask Dr. Alter directly any questions you might have. I think, oh, okay, can you tell me your opinion on, okay, I'm gonna try it. Anastrozole?
Anastrozole, okay.
Electrozole?
So what happens is that as a child, typically a boy, is heading to the end of growth, that we would of course love growth to be prolonged. And we know that estrogen, actually, like the female famous hormone estrogen that causes breast development and periods, boys make that too. And so there's a medicine called anastrozole, which blocks the body from making estrogen. So if you do that to a boy, the hope is that you might prolong growth. I will tell you that it is not approved, meaning that there's been the full consensus isn't out on whether it's a good thing or bad thing. It does make the testosterone levels look really weird. It makes them rise. I can tell you personally, I probably have maybe 10 to 12 patients on it. Often it comes out on the patient's request, but not always. And I find it actually works pretty well. Yeah.
Rachel asks, does hypothalamic obesity impact growth?
Yeah, it is, when grandma says eat more to help grow, it's actually true that our patients that have regular obesity, not with the pituitary thing, you can see that the growth rate is increasing, and you probably can make someone taller just by overfeeding them. And so some of these kids do grow a little bit more as far as that. Of course, if they're gaining so much weight that the thyroid levels are now low, that will impact the growth in a negative way. So it's still a balance, but it's a fair question.
Sorry, I think Leah had a follow-up just about the anastrozole question about bone impact.
I don't want to go on video.
Oh, okay, that's fine.
Sure.
But,
That's fine.
thank you so much. This has been super helpful. I was just curious if the patients that you have on that anastrozole has it negatively impacted their bone density?
Well, we would only know that if we're checking it, and we don't have a specific rule about checking it. If a patient's been on it a long time, I like to check a DEXA scan, DXA or DEXA, which is a special X-ray test which looks at bone density. But I haven't seen it having an effect. But there's if you're really curious, you should look up this name, Nellie, N-E-L-L-Y, Morris, M-A-U-R-A-S, Nellie Morris. She's the
Okay.
doctor in Florida that's done the most research on this.
Oh, thank you so much. Appreciate it.
We just have a couple more minutes if anyone has. Okay, Elizabeth has a question about DI and bedwetting.
Yeah.
It's a lot to type. Oh, yes. You may unmute and ask the question.
Hi, I don't mind. So my 8-year-old son takes desmopressin twice a day, roughly 7:30 a.m. and 7:30 p.m. And he is still having some problems with bedwetting. He wears a pull-up at night. Oftentimes he even soaks through them. We do get him up before we go to bed around 11:30 or 12.
Right.
Take him to the bathroom. But aside from us setting alarms to wake up every 2 hours, which I don't know that that's really going to fly long term. Do you have any suggestions? Is there, do we need to really look at more desmopressin? Is there a behavioral concern?
Okay, so let me go over that. And so last week I saw, I think 3 boys in a row that were much older that's had bedwetting, but none of them had pituitary problems, by the way. They were all just growth evaluations. So it is a problem that occurred. I would want to know, is there excessive urination during the day, excessive urination at night? Because new onset type 1 diabetes, which is not what we're concerned about, it often has new onset bedwetting because of the such high volume of urine. So both diabetes insipidus and diabetes mellitus, sugar diabetes, present with high urination. And if they're 8 or 9, new bedwetting is almost always seen. So we do know that high volumes of urine will take an 8-year-old into having bedwetting. So that's my question. Do you think that the urine volume is high?
I don't know that it's any higher than during the day. And it's been happening like this for
Even in the day, do you feel like, do you have other kids too?
Yes, he definitely has always gone more often and a lot more than my older son.
Okay. The next question, have you had problems with low sodiums at all?
No.
To your knowledge. Okay. And what's your child's diagnosis, by the way?
He has craniopharyngioma, diabetes insipidus, adrenal insufficiency.
Got it. Craniopharyngioma and associated endocrine issues. Typically, when someone gives me that history, I try to do a little bit higher nighttime DDAVP. I'm not telling you specific advice because maybe you tell me that and doctors say, wait, what is she talking about? The kid had a low sodium, last year, and we were so concerned, stuff like that. So you'd have to discuss it. But I would, if this is my patient without other factors, I would often go, what's your dose of DDAVP at bedtime or desmopressin?
It's a 0.5 tab.
Okay, so 50 micrograms is 0.05 milligrams. So maybe they need 3/4 or 1. And
Okay, thank you. I appreciate
discuss it
it.
with your team. Yeah. Are there labs that are related to depression? Only thyroid labs, really. There's no magic labs for depression that I know of. Yeah, it's life is
Okay.
complex.
Always lots to discuss around DI. That's probably another session, but thank you so much, Dr. Alter. We really appreciate your time today. And we will be starting our next session at 3 p.m. Eastern time. So we hope to see you all in the next sessions. And Dr. Alter will be rejoining us at 4 p.m. Eastern time for the general panel QA. So thanks so much.